If the morphology is really bad, even if the count and motility is good, we can't ignore it. So we know that makes a big difference. It's tough in the middle, though. It's tough in the middle. When they're good, they're good. When they're bad, they're bad. It's that middle one that's really hard. So I really find it difficult to tell patients who have that middle range if the morphology actually makes a difference in their outcomes. So that's a little confusing for everyone, but that's the reality. Yep.
Right. And how is morphology calculated on a semen analysis? Because you see 2%, Kruger criteria, 4%. Can you talk about that? Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Center, otherwise known as Our Baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together.
Today's episode of My Fertility Podcast, we are joined by Dr. Keith Jarvi, who is a professor of surgery and the head of urology at Mount Sinai Hospital in Toronto, Canada. He is the director of the Murray Koffler Urologic Wellness Center at Mount Sinai Hospital, which is the largest male infertility clinic in Canada, and is working to develop less invasive ways to identify and treat male infertility. His other main clinical interests include microsurgical reconstruction techniques, sperm retrieval techniques, and genetic abnormalities. We are joined by an absolute leader when it comes to male infertility in all of Canada. We have a multitude of questions for Dr. Jarvi all about male infertility and sperm. We can't ask all of them today, so we're going to be doing a multi-part series all about sperm, the semen analysis, and male fertility. And we are so excited to dive right in. All right, Dr. Jarvi, let's talk about the semen analysis. This is something that we spend lots of time talking about with patients every day. But from your perspective, what aspects of the test are important when it comes to predicting fertility or helping to manage infertility?
Really, really good question. I mean, the semen analysis is the core test for male infertility, of course. And any man who's been trying, or a couple who's been trying for at least a year, should have a semen analysis, or at least suspect there's an issue. If there's a low sperm count, that's going to be a real signal that there's a problem going on. Probably more importantly, actually, is the sperm motility. If the sperm motility is very, very low, the chance of the couple conceiving is actually extremely low. And those couples really need assistance. And finally, the other test that I like to use fairly commonly now is the sperm DNA quality test, which is a measure of how many strands of the DNA are broken. And that's particularly good for patients who are considering going through the IVF program. So it's a little bit of all of them, okay? It's not that easy. It's not just one or the other. If you have a low count, important. If you have a very low motility, extremely important. And if you have a loss of DNA damage, that really is a very bad sign for couples to have normal live births.
I have a lot of questions about the DNA fragmentation, but before we get into that, can you talk about morphology on a semen analysis? What it is, why it's so confusing? I know I have a lot of patients that get really hung up on that.
So it's not only patients are confused by it, it's actually virtually every doctor is confused by it. So if you look at a sperm, it's supposed to look perfect. It's supposed to have this nice oval head attached to a tail that's about 3 times longer than the head. And if there's any imperfections in that package, it's considered to be abnormal. But we know the sperm that are a little bit abnormal can cause a conception. So the question is, how abnormal is abnormal? So let's put it this way. If it's a really abnormal sperm, say the head is missing, called like pinhead sperm, it's kind of cool. You just see the tails wiggling around with the little heads going at the top of them. That patient's not going to have kids, guaranteed. But if it looks perfectly like little oval, nice little tail on it, and maybe there's a little extra lump on the mid piece of the sperm, those couples may actually have kids. So it's a really tricky question. Right now, I'd say the hardest thing for labs to measure is actually the morphology, because every person who measures it takes a look at it and sees something different. So if you're looking for perfection, you look again a month later, you actually have a different idea what perfection is. So we pretty well know, with most of the andrology labs, know what's really bad. They also know what's really good. They have trouble in the middle. So generally speaking, if we have morphology, which is low, if the sperm count, motility is also good, we shouldn't generally tend to ignore it. If the morphology is really bad, even if the count and motility is good, we can't ignore it. So we know that makes a big difference. It's tough in the middle, though. It's tough in the middle. When they're good, they're good. When they're bad, they're bad. It's that middle one that's really hard. So I really find it difficult to tell patients who have that middle range if the morphology actually makes a difference in their outcomes. So that's a little confusing for everyone, but that's the reality.
Right. And how is morphology calculated on a semen analysis? Because you see 2%, Kruger criteria, 4%. Can you talk about that?
Yeah. So the strict morphology, the sperm has to look perfect, has to have a nice oval head, that nice long tail, has to have a nice cap on it, which looks basically perfect. And if 4% or more of the sperm look perfect, that's considered to be normal range. Okay, so that's considered. There's another one, which is a less strict morphology. And they sort of say, okay, if there's a little bit of a lump extra on the tail, or maybe the head's not as well formed as it should be, that's a less strict morphology. And sometimes you'll also see a lab that will say 30% normal morphology. It depends on what they're reporting. Most of the labs now will report that first one, which is a strict morphology, and they'll say 2 or 3% normal or 5% normal. That's how they do it. Those are actually usually read by eye. So the problem is each one of those technologists is going to read it just a little bit differently. So that morphology number one may be the same as number two, but in fact, they may read them differently. So basically, tricky question. Again, if it's really bad, it's a good test. And it's really good, it's a good test. It's those in-between ones where we have difficulty determining how much of a difference it makes.
I'm going to probe even further on this because this is a question that I get probed about from patients, right? You know, they get a semen analysis done at a lab that will use that Kruger strict criteria. Morphology comes back 1% normal forms or even 0% normal forms. And so it's like, oh my God, like I'm never going to have a baby. I'm never going to get pregnant with this sperm. It says 0% are normal. And how do you counsel patients about that? Or how do you interpret that?
That's when you have to look in the details of the report. So the 1 or 2% normal forms, I look in the details, and the details will say how many abnormalities there are per sperm. And if there's more than 2 abnormalities per sperm, roughly about 2.5 abnormalities per sperm, that's a very bad sign. If there's a really abnormal sperm, if they say like there's 2 heads in the sperm, that's a really bad sign. But if you just take 1%, those couples may actually have children quite easily. So 1% by itself, that's when you have to actually look into the details of what that 1% normal actually means. Again, if it's a really bad ones where there's lots of defects, or there's 2 heads, or there's 2 tails going on, that's a bad sign. But if it's just 1% look perfectly normal and then 20% actually look pretty good, that's actually not such a bad prognosis for the couple. But it's a tricky one. I realize when the couple gets back the information saying, okay, you have 1% normal, that's an abnormal number, that's really shocking for the couple to look at. I absolutely get that. I get that all the time. I have exactly the same problem you have.
Right. And on that topic, I mean, we all know the answer to this question, but I think it's worth mentioning. A lot of couples get worried, like, okay, so you're telling me I could conceive, but now I'm really worried I'm going to conceive an quote unquote abnormal child because I have so much abnormal sperm. So now I don't even want to try anymore because of all of these abnormal sperm, and I'm worried I'm going to have a child with genetic or chromosomal abnormalities because of the abnormal sperm.
Right.
That's not the case, but you can talk about that, please.
Yeah, I get exactly the same question all the time. You know, I have abnormal sperm. Is it going to result in an abnormal child? And the answer is basically no.
Yes.
All of us know that that's not the case. Probably what happens is those normal sperm are picked out in the process. And out of those 70 million sperm, the ones that make it through tend to be the best ones. And probably that's what happens is the best one gets chosen in the process. And it doesn't result in any higher risk to have abnormalities in the kids afterwards.
Thank you for saying that. It comes up a lot.
And kind of along those same lines, as talking about morphology, another question or another concern that always comes up is, why do different andrology labs or different labs that run semen analyses use such different quote unquote normal values? Like when you're looking at the sperm count or motility, or, some places have vitality I've seen on semen analyses, right? Why the variation? What's that about?
So there is a standard. The World Health Organization has a standard that everyone should be using across the board. That standard has changed throughout the years. And sometimes labs will take a little bit of time to catch up to the standards. And every couple of years, the WHO, World Health Organization, will change those standards. And I'll look at different labs, and they haven't changed their normals yet. And I think that's probably that's more what happens than anything else. There's also labs that you mentioned, a really good test, the viability test. In other words, how many sperm are alive and how many might be dead. That test is not measured by all labs, but it should be. That should be a standard test in all labs right now doing semen analysis.
Can you tell us a bit more about this viability testing, what it is, what it does, what it means, how it's done?
Excellent. Okay. So viability test is simply how many sperm are alive or dead. It's a fairly simple test to do. The lab, they put a little dye on the sperm, and they can tell from the color of the sperm if that's a live or dead sperm. And then basically they count how many are alive or dead. And this is really important for those patients that have low sperm motility, because low sperm motility could mean the sperm are actually alive, just not moving, or those sperm are dead. And that's a totally different thing. If you have sperm that are alive but just not moving, it could be the tail is a problem. But if they're dead, they're dead. They're not moving because they're dead. So you need the viability, particularly for those where the sperm motility is low. Very important.
Now, if the sperm motility is low, regardless of whether they're alive or dead, how does the viability really change what we do as fertility specialists? Because we still have to do the sperm wash and get the motile sperm.
That's a really good question. At the end of it, if the sperm are dead, let's say you have 80% of the sperm that are dead, those patients don't do very well just with an intrauterine insemination. They probably need in vitro fertilization to succeed. The other problem with if there's a lot of sperm that are already dead, quite often the remaining sperm are also abnormal. They may have damaged DNA because they're either dead or on the way to becoming dead. So, they may not be dead at that point, but they're predisposed to dying pretty quickly. So a lot of them will already have breaks in their DNA, and they're on that path to death already. So if you look at those men who have very low numbers of live sperm, you do the DNA fragmentation testing, it's almost inevitably very high. And we actually should talk about DNA fragmentation in a little bit, but just the precursor is, there's a lot of DNA fragmentation in these patients, no matter what we do, they don't do very well. And those are patients where it's really important to try to reverse that process. So circling back, if you have a patient with a significant number of dead sperm in there, you can't treat them the same way as if they had live sperm just not moving. They don't do very well with in vitro fertilization. And those are patients who should see a urologist to try to improve the live sperm rates. Because if you improve that, you improve everything. You improve the DNA fragmentation, you improve the IVF outcomes. Those are patients where it's really important to dig in and find out why that sperm is not moving and why it's dead, and to see if we can reverse that whole process.
Excellent. Thank you for that explanation.
One thing that we really haven't mentioned in all of the metrics of the semen analysis yet is volume of the ejaculation. Now, this is something that, a lot of people who produce sperm get kind of hung up on in terms of the volume and concerns about the volume. Does it matter? What should we be looking for?
It's an interesting one because volume is very important. Of course, if you have 10 million sperm per milliliter and you have half a milliliter, there's 5 million sperm there. If you have 3 milliliters, you have 30 million sperm. So just that bulk numbers by increasing changes what you can do on your side for the couple. That's very important. But maybe a sort of a more fundamental issue is, why is the volume low in those patients? Number one, maybe they missed a jar. That happens all the time.
Happens all the time.
Patients don't normally ejaculate into a container. Now, if they do, they probably shouldn't be in the fertility clinic in the first place, right? So it's not a normal thing. And it's really common for men to have difficulty providing a specimen. That's normal. I think it's incredibly important to recognize that this is a common problem that men would face. And it's just perfectly normal. It doesn't mean that they're abnormal, that they have a problem. Otherwise, this is just a weird situation. You're putting men in a lot of pressure. And a lot of men have that issue where they either can't provide a specimen or they just can't get it into the jar. That's number one. But then the second one is, let's say you do it again and you find that again it's low. Sometimes those patients are missing the tubing, or maybe the tubing which takes the sperm through may be missing. And that's very important to understand that. And then sometimes their prostate area is blocked. And then sometimes diabetes results in abnormal nerve conduction to the prostate, so nothing comes forward. So if it's a nerve problem, like from diabetes, that's usually pretty easily treated by us. If it's a blockage problem, that's a hard one to treat. So finding out the cause of the low volume is very important. And if we can treat it, they usually do very, very well. Those are usually ones where if we find a cause, we are very successful in treating them.
With the ongoing effort of fertility myth busting today, another common question, or common anxiety, I should say, that patients have is, my volume was really low because I was really stressed or because I was really nervous.
Mm-hmm.
Is there a relationship between stress levels when producing a sample and volume?
The short answer is yes. I mean, it's not just hitting the jar. It's also with full ejaculation, you're going to have more fluid coming out. And also, they're under stress, you just can't even perform. So patients might find in that situation, it's just easier to go home, repeat the test at home, relax at home, and then bring it in from home. And then you worry about the length of time it takes to get the sample to the lab to make sure that the sample isn't old. But that's actually less important than the men being relaxed and being able to provide a sample. So, you can't win, but you probably don't. You're going to lose more in the stress region than you're going to lose in the keeping it an hour and a half.
Okay, so I think the time has come to talk about this famous DNA fragmentation. It is a complex topic, and you're the best person in Canada, if not in the world, to talk about it. Tell us what DNA fragmentation is. Give us a little primer. What the test is, what does it mean? How can it affect fertility outcomes? And I have a million more questions about it, but let's start with that.
So the DNA in the sperm is really tightly compacted, so it's protected and it doesn't break. But if there's a lot of things called reactive oxygen species, or these things which are sort of can damage the DNA, there's going to be damage in all the DNA anyway. There's always a little bit of damage, but that damage can be repaired. If the damage is more extensive or in more areas, then it's going to be difficult to repair it. And then when that couple tries to have children, unfortunately, with that damaged DNA, it may cause difficulty not only with the fertilization process, but more importantly, downstream in actually having a live baby at the end of it. So there's going to be a higher pregnancy loss rates. So yes, there's a reason. There's a lot of ways of measuring, but what they're trying to do is essentially they're trying to look for colors, which will change as the amount of DNA damage increases in sperm. And then what you can usually do is look out by eye under a microscope, or you put it through a flow cytometer, which essentially is a machine that just passes through like 5,000 sperm. It is very fast, and it gives you an idea about how much DNA damage there is per sperm. If the DNA damage is very high, that's really worth trying to repair, trying to find something that can reverse that process. mainly because it's one of these things that has a dramatic impact for couples who are trying to have kids on their own. It affects assisted reproductions like intrauterine insemination, and it adversely affects in vitro fertilization. So it affects it at all points. Was that a good start?
That was a good start. Which patients should we be doing DNA fragmentations on?
Good question. This is still controversial. The guidelines have changed very recently, but I'll tell you what the guidelines in general will say. You're looking at someone who has a problem having a pregnancy with recurrent pregnancy losses. Maybe the couple that had pregnancy and lost 1, 2, or more pregnancies. That's one of the things you should test for. But there are other centers that think that all men with infertility, in other words, with a low sperm count or low sperm motility, should have a DNA fragmentation test. There's not a lot of consistency there. I think if you are considering going through an in vitro fertilization procedure, it's a valuable test to have to help you predict whether or not you have a higher chance of losing a pregnancy with the IVF procedure. I still think it's a valuable test to have.
So even if the sperm is normal, let's say we're going into IVF because the female partner is, let's say, 39 or 40 years old,
Or IVF because the tubes are blocked.
or endometriosis. So there is a female component, I guess that's the point. And there is normal sperm on a semen analysis parameter. Do you think that couples should have a DNA fragmentation before their first IVF cycle?
This is really controversial. So there's no consensus on this whatsoever. But I'll tell you that we know that even if the sperm tests are normal, about 10% of the time there's going to be a higher than expected DNA fragmentation. Okay. That's where I think you should talk to the patient about it. If they're saying, okay, listen, I'm not going to do anything with this, it's very unlikely that it's going to actually have an impact on the next IVF procedure, fine. But I'll have other patients say, I want to know everything about me before I go through that. So globally, I don't recommend it. I agree with you. Those are couples where it's very unlikely, but still 10% of the time, I think that's a low number. But the patients are going to tell me if they think it's a high number. If they think it's a high number, we'll do it. If they think it's a low number, I'd feel very comfortable not doing a test at all.
In terms of DNA fragmentation values, like I've seen reports like less than 15%, 15 to 30% and higher. What would you consider a worrisome DNA fragmentation value?
It depends on how the test is done. The test which is done with the flow cytometer, usually that's above 30%, is considered to be a risk for lower pregnancy rates and higher pregnancy loss rates. But the higher you go, the worse it is. Should we be getting that range of 60, 70%? Unfortunately, the prognosis is not very good. And if you're getting down to that low 30 range, it's actually pretty close to normal. So there's no real cutoff. We report a cutoff, but if you're 31, are you actually much worse than 29? His answer is no. If you're 50, you are much worse than 20.
Right.
So we normally say 30% roughly, and then the higher you go, the worse the prognosis.
So let's extend out that scenario that we talked about earlier a little bit here. So, again, a couple is about to do IVF, their first IVF cycle. Let's say patient with eggs has endometriosis, maybe she's a little bit older, and we're doing IVF now. I do a sperm DNA fragmentation despite a normal semen analysis, and it comes back elevated. Let's say it's, 40%. What are the next steps? Where should you go from there?
That's somewhere where I think it's worth looking at all the potential ways of reducing that. So there are a lot of things that you do automatically anyway, like men should probably be on some kind of a supplement. And if they're on an antioxidant, that has been shown to reduce the DNA fragmentation rates. So often we'll give the men supplements anyway, just because there's no risk in having them. It's a relatively low cost, and we don't know who's going to help, honestly, at the end of the line. So I think giving them supplements, we know that's going to decrease it on average. Things like, believe it or not, lifestyle, weight loss, smoking cessation, marijuana cessation, those kind of things have been shown to reduce that. These are the patients where it's worth going after all those little things to see if you can reduce the numbers. Then we also try scrotal cooling. Don't get me started on that one. When I bring mentions to patients, it's like, what? So, so what it is the higher the temperature around the scrotum, the poorer the sperm production and sperm quality is. So if you can lower that temperature, then you're going to potentially improve the sperm quality. So those are patients where I basically throw the kitchen sink at them. So we'll put them on supplements, vitamins, weight loss, smoking cessation. We'll try scrotal cooling on them to see if that will reduce it. Again, it's important. If you can get it from 40 to 30, you've actually done a big service for the patient, even if they go through IVF. So final one in that list is a varicocele repair. Now, varicocele is in large veins around the testicle, usually on the left side. And by repairing those, what we actually do is we lower the temperature of the testicle. Same thing as scrotal cooling. But that's a surgical procedure to do it. So I tend to leave that to the very end because it's a surgical procedure to see if we can get away without doing the surgery on the patients. But that's something we offer in that particular situation with a high DFI and if they haven't responded to all the standard techniques.
So just for our listeners, DFI stands for DNA fragmentation index. So we're still talking about DNA fragmentation.
Thank you very much.
And so can you talk a little bit more about scrotal cooling? Like what is the exact protocol? Like what do they use? How many times a day? How many days? How often in the day? Can you give us the exact protocol?
Yeah. So there are devices that you can use that cup the testicle. And what they do is they provide a little bit of cooling around the testicle. And most of the devices, though, tend to get warm pretty quickly. So they're actually hard to use for patients. So if they're going to work, a man goes to work, he may have to have these little devices that cup the testicle and cools the area down. It can be quite hard to take that device, then find a freezer when you're at work and put it back out again. So it's a very demanding kind of treatment for our patients just because practically it doesn't usually fit in with the regular workday of most patients. So I say, whatever they can do, whatever works for them that they can actually successfully manage to cool the area because they have to actually use it for 3 months. It's not just a 1-month window. They have to use it consistently for 3 months. So if they're able to use it consistently as much as they can during the day, I did a study on my own patients, and we actually got up to about an hour a day on average for the patients, which was pretty good. And it seemed to make a difference in terms of sperm quality, even at 1 hour. So I don't know if you actually used it 24 hours a day, if it would be better, but it's not practical for the majority of my patients. Most of the time, what happens is they'll go to work, they'll come home, they'll use it when they get home. And if they get an hour out of it, I think that's a really good effort on the patient's part.
And pardon my ignorance, I don't have testicles, but do you need a device or can you use anything cold?
You can use anything cold. That is a actually a very good question because all of the devices right now that are commonly used have some kind of a freezing agent inside. And it could be either like a cup or a little block that sits under there, but you can actually put cold vegetables on, something like that. Don't make it too heavy because that's uncomfortable. Whatever is practical for the patients, they can use it.
Okay, so that's good. So they can watch TV and just put something cold and sit on top of it. And I would assume you need to be wearing like some layer of clothing, not to put it directly on something cold because then
you don't want to freeze it. And the converse is, of course, you want to have them avoid really tight clothing the other times. So you want to make sure that they're not wearing those Saturday Night Fever kind of clothing.
No Speedos.
No Speedos. Yeah. You want to make sure that because there actually are devices that have been used that are tight that cause men to become infertile.
Oh, wow.
So we want to do the reverse.
Right.
They stay open, cool, and everything is a little bit cooled down at all times.
Speaking of cooling and heat on the scrotum, I think we're a little bit off topic here, but how about the idea of using a laptop on your thigh? Because I've heard that being an issue for sperm or sitting, like if you're an Uber driver and you're sitting in a car for a very long time or working in a kitchen.
Yeah. So people whose work depends upon being in a hot environment, they will have a reduction in sperm parameters. Though the problem is you can't really take them out of that because then they may lose their job and then they won't have enough money to raise their children. So it's like this catch-22. So those kind of jobs where there's heat around the area, do whatever is required to try to minimize that heat exposure. And that's basically all it is. There's so many permutations and combinations of jobs where heat exposure is almost a requisite of the job. Say fighter pilots and people who drive all the time. But there's ways that they could mitigate that heat, that problem that arises. And if they can think innovatively, try to reduce the heat, as long as they understand, they can usually do it.
There's also been, some talk about this idea of whether sperm should be aspirated directly from the testicle as opposed to using ejaculated sperm, that might have lower DNA fragmentation values. What are your thoughts on that, or what's the latest research or literature about that?
So again, this is really controversial. And there's differences between how North Americans approach it and how Europeans approach it. Presently, we don't automatically offer sperm retrieval from the testicle for patients who have very high DNA fragmentation rates. We don't automatically offer it. We will offer it if patients have tried an IVF cycle and it has gone very badly, then we'll try to retrieve it from the testicle. It's true, absolutely true, that the DNA quality in the testicle is actually better than it is in ejaculation. You're basically fresh to the source. You're going to be better than when you go through all that processing of getting out. You have to go through all the tubes and get out, and it gets damaged on the way out. So if you can get it earlier on, there's less DNA damage. Problem is earlier on, it's also less mature. So you lose a bit and you gain a bit. It's still controversial right now what to do with these patients. We have not yet flipped over to offering sperm retrieval for men who have persistently high DNA damage, but we will offer it again if there's a very bad outcome for an IVF cycle and the DNA quality is very poor. We will offer it now.
So that's interesting. So let's say we have someone who is 40 and do their first IVF cycle, and we do a DNA fragmentation and we find that it's, I don't know, let's say 35, 40%. So now you have that struggle of like spending time working on decreasing the DNA fragmentation. Maybe 3 months later is still the same or higher, but now she's 3 months older, right? And we know the impact the age has on fertility. So at some point, you might have to say, no, we have to do this IVF, DNA fragmentation or not, because we can't keep waiting 3 months and 3 months and 3 months. And then the older she gets, the worse the outcome is going to be. So if you are going into an IVF cycle knowing that your DNA fragmentation is high, but you've never done one, so you don't know what the outcome is going to be, would you say if that is the first cycle to do an ejaculated sperm, knowing that you have high DNA fragmentation, or do an aspiration?
Yeah, I mean, this is sort of the art of the REIs and the infertility people, is to sort of individualize the treatment, which would optimize the care using the best information that we have. And the information is not perfect. We have to recognize our information is not perfect here. So if I had someone with the DFI at 35, I probably wouldn't do it right now. We may change our mind a year from now. But if that same person came in with the DFI of 50 or 60, would be more inclined to offer it if the couple did not have the time to wait for another cycle. I agree with you there. These are sort of gray zones. We shouldn't be too rigid how we offer it to the patients. We're trying to optimize their chances to have a live, healthy child. And we're working with incomplete information.
On a time issue.
Yeah, I think patients understand that, and they may want us to do something which doesn't make sense, in which case I will usually say no. But a lot of times the patients say, listen, I'm this age, I haven't got a lot of time to waste. Am I going to increase my odds even by 1 or 2%? And then I leave it to them whether or not that would be something that they would choose.
Right. That makes sense. And another things I've heard in terms of DNA fragmentation is this question of maybe doing 2 ejaculations or ejaculating the day before the retrieval procedure or X number of hours before the ejaculation that is going to be used in the IVF cycle. What are your thoughts on that?
A lot of this is being done now just as routine. And so doing a double ejaculation, on average, the second ejaculation has less DNA damage than the first one, on average. Doesn't work on everybody. There's some patients where it doesn't touch it at all. And then there's other patients where it drops by 10% or more on the second test. So I think that's a very good technique to manage couples where you think you're going to go through an IVF procedure anyway, but you want to choose the optimum sperm for the cycle. And then afterwards, you're going to process it by whatever technique, which will choose the best sperm that's available. But despite that, there still is going to be a higher pregnancy loss rate than we would expect in couples who would have normal DFR.
So a double ejaculation, are we talking like an hour apart, like back to back if the man can do it, which I know might not be easy? Are we talking like, because I've also heard like doing it the day before the egg retrieval procedure might help as well.
Yeah. So the protocols vary depending upon which centers you're looking at. Some people are doing daily ejaculations for 3 to 5 days, followed by an ejaculation in the morning for the IVF procedure. And there's some centers that are doing 2 ejaculations 1 to 3 hours apart. And I don't think the jury is out yet on which is the best approach to this. I think both do reduce the DNA fragmentation in the last sample. I think you could offer either one, frankly, right now. It's probably more practical to offer 2 in one day because then you have the first sample and the second sample, and you can work with either one. What happens is the sample is very poor after 3 or 4 days. That's one of the things that we sort of have recommended 2 in one day. Though, frankly, if the guy's got 100 million sperm, I'm less concerned about that.
Right. Along the line of DNA fragmentation and timelines and, doing IVF versus trying to work on DNA fragmentation, how long does somebody need to be on cooling therapy or be taking vitamins and supplements to start seeing a difference? And then what's the average length of time that somebody might be on these things before you might say, okay, yeah, like you can do your IVF now?
The sperm takes almost 3 months to develop. So we like to say it takes 3 months for that impact to occur with the cooling or with the vitamins or with anything you may offer them. But this is interesting. The cooling may also affect sperm after they've made it into the tubing. So the effect of cooling may actually be faster than we think. It may actually be like a 2-week period. If you decided that the couple want to go through IVF in say a month from now, and you don't have that 3-month window, I still think the cooling is worth doing for those couples because, first of all, it doesn't hurt anything. There's no risk. And the effect may actually be faster than we think.
Interesting.
In general, 3 months. But if you've got no time, I still would try it.
In terms of DNA fragmentation, here's a controversial question for you. Why isn't this test covered by OHIP?
OHIP doesn't cover new testing very easily at all. I think if patients had, basically if they speak to their MPPs, that would probably be the way to try to change this, the financing for this test. Honestly, that's way out of my area.
Fair enough. No, it
Well,
was a bit of a trick question, but
what is the average cost of a DNA fragmentation?
I honestly don't know. It runs anywhere between, this is just hearing from the different labs that do them. I think it's between like 200 to 350 for the test. You know more than I do about the cost, but that's just from my rough estimate from what's out there in Ontario.
Yeah, we normally send patients to flow labs to have them done, but they pay flow labs directly, so I'm not sure. But that's usually the number I mentioned, $200 to $300.
Yeah.
All right. So switching gears a little bit, moving away from DNA fragmentation, another measure that comes up on some semen analyses, and not all of them, is anti-sperm antibodies. What are they? What's the deal with it? Should we be worried? Should we be concerned about that?
So the anti-sperm antibodies, these are antibodies that the body produces against its own sperm. Sperm are considered to be foreign invaders. So anti-sperm antibodies can be found in the fluid, the seminal plasma. Women can also have anti-sperm antibodies in their system too, which may attack the sperm that comes in. Okay, so you can have it in both sides. Let's just look at the male factor. So what can happen with anti-sperm antibodies is the sperm can actually stick together. So you'll see the sperm heads sticking together and they're wiggling their tails, but they're not going anywhere because the antibodies are actually holding them together. These are like little bits of things that stick out of the surface of the sperm. And if they stick together, they can stop the sperm from moving very well. They can also block the important sites on the sperm that bind to an egg. So you can find antibodies in areas which block the sperm from fertilizing an egg too. So what we test usually is we have a test for antibodies, which usually is some kind of a bead. And on this bead, there's something called an anti-sperm antibody, which is another antibody which is attached to this bead, which then attaches to the antibody on the sperm. And then usually you see the sperm and the beads together and then measure that. That's sort of the most typical anti-sperm antibody test that you'll see. And then you'll see a measure like, 50% of the sperm with antibodies, and the sperm, maybe it's on the head of the sperm or the tail of the sperm, the tip tail of the sperm. Generally, we will use the anti-sperm antibody testing if the sperm seem to be stuck together but moving still. It's called agglutination, where the sperm, they're just stuck in the tails are moving, but the heads are not going anywhere because they're stuck together. We'll often do anti-sperm antibodies there. The problem with anti-sperm antibodies is we don't have any effective treatments for them. The effective management is IVF. There's a lot of anti-sperm antibodies useful to identify because you'll save that couple a lot of grief. You'll take them straight to IVF if there's a lot, and they'll save a lot of time on the interim steps where the success rates can be very low if they have a lot of anti-sperm antibodies. And they'll go straight to, usually the treatment is in vitro fertilization for them. And it's very effective, very effective.
Mm-hmm.
So important one to do, particularly if the sperm are stuck together. And it can save patients a lot of time and money if we can identify that early on.
What are some of the causes for anti-sperm antibody in men?
In men. So basically, anti-sperm antibodies mean that sperm has somehow gotten into the bloodstream of men. So the sperm are protected from the responses to the invader response. So normally, if you put a foreign body in, you'll create antibodies, that foreign body, which will come in and attack it. And then that will destroy that invader. So sperm are actually considered foreign bodies, but they're in a protected site in the testicle. But if they get through into the bloodstream, then you'll start getting that antibody response. And with that antibody response, you'll actually then attack the sperm. So things that can make the sperm go into the blood, like for example, if the man had a vasectomy, you're going to get a little bit of leakage into the blood. If they've had an infection, if they've had trauma to the testicle, those are kinds of things that could leak sperm into the bloodstream and cause antibodies. Most of the time, we actually don't know why men have antibodies. It's just they have them and we don't know why. And it's probably one of like an infection or trauma or something that happened.
Yeah, I was going to say that because I see it quite often in my practice where there is anti-sperm antibodies. And I say, have you had any of these issues? And they're like, no, nothing has happened. So it's like, it's a mystery.
But everyone plays soccer, right? Or everyone plays
Right.
It's part of the game. Part of the game.
Now, once you have anti-sperm antibodies, does that mean they're always going to be present? Or is that something that you might see come and go?
They can come and go. There's no effective, safe treatment to remove them from the system. So people used to use steroids, and then you had steroid effects. So they don't really use that anymore. And since there's a really effective treatment for anti-sperm antibodies, which is in vitro fertilization, we don't need to offer them these risky therapies. So it's actually very effective to use IVF. Do anti-sperm antibodies come and go? Yes. But generally speaking, if there's a lot of anti-sperm antibodies, they're probably going to be there for a long period of time.
Thank you so much, Dr. Jarvi. This has been so informative. I learned a lot. I'm going to claim my CME points. I'm so privileged, the two of us, to have your expertise all to ourselves. And now we're going to share with our listeners and our community. So thank you so much for your time. For those of you who don't know, it's actually 8 p.m. on a Monday night. And Dr. Jarvi, after a long day of clinical duties, we logged on at 6 p.m. and it's now 8 p.m. That's what he was doing on a Monday night, spending the time with us and sharing his knowledge and his wisdom from many, many years of experience.
Thank you very much.
Thank you.
Bye.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.